Right, I'm going to make a start. I think people will probably keep joining, but I'm keen to start because we've got limited time. The other thing to say is that as this is being recorded, we will be able to share this message much more widely as well after the sessions. So it'll be we'll be able to share it and share the things that we talk about and share the presentations more widely. So thank you very much to everybody that has joined us for today's webinar on Fit2Sit. Thank you especially to our speakers, and I'll introduce them later in this. And just to say, I'll run through the agenda and then the housekeeping, and then run straight into the presentations, and then there'll be chance for questions and answers. So we're very, very lucky to have Lizzie Roebuck with us today, who's going to give us a kind of paramedic perspective on Fit2Sit. She's a regional clinical fellow and a paramedic in the northeastern Yorkshire, and she'll do a much better introduction of herself than I've been able to when she presents. She'll be followed by Dr. James Harrison, who's an emergency medicine consultant at the North Mid. I'm sure he'll also do a better introduction of himself, and he's going to give us kind of an acute perspective on Fit2Sit and some of the learning from the kind of experiences of the North Mid. We're aiming to allow 15 to 20 minutes for questions, and we may have a look at some Menti during that time. And then we'll close, kind of signpost to resources, and we can talk about anything that comes next. So that's our agenda for today, and thank you very much again for joining us. Just some housekeeping. As I said at the start, we will be recording this, which is a great way of being able to share it much more widely after the session. So just to make you aware of that. If there's anything that we can't cover and any questions that we don't get to, my email address is there, and you're welcome to use it afterwards to ask anything or kind of follow up on anything that's not covered within the session. Please do use the chat function to ask questions, share ideas, comments. It's really, really useful to us. The more you ask, the more we'll get out of it. And it's just fantastic feedback for the speakers as well. And as I said, we will have time after the two speakers for questions and answers. My plan is to allow the two speakers to speak and then open to wider questions. We'll be sharing resources and links in the chat function during the webinar, and if there's anything that you particularly want to know or access to, please again put it in there. But we'll also encourage you to put your hands up at the end of the presentations and ask questions if there's something that you've picked up. And then most importantly, thank you for being here, and we really hope that you take something away from this, that it's useful, and we welcome any feedback, kind of how you found it and what you'd like to see next time. That would be really, really helpful. So just a very quick oversight. What are we hoping for from today's session? I think a reminder of why we think Fit2Sit is important, and just really going back to the patient and a good Daily Mail picture, which I think has been shared quite a lot, but it's deconditioning in older people with frailty may start within hours if they're lying on a trolley or bed. So up to 65% of older people experience decline in function during hospitalisation. It's really just to say that the right thing for patients may not be to lie on a trolley, and maybe to mobilise them, to get them ambulated and to treat them in a different way. And we'll be talking about that during this webinar. And also it does help with making sure they get the right treatment in the right place at the right time. And I know that both Lizzie and James will cover that. Lizzie and James will be sharing experience of their approaches to Fit2Sit and hopefully generating ideas and discussion. We want to make sure, and I'll repeat this, but it's really important for us that we allow time for questions, debate, discussion, and we really do want to help signpost resources if needed. And if there's anything that we don't cover, as I said, please do put it in the chat or email me afterwards, and we can cover it afterwards. So that's plenty of me, and without further ado, I'm going to hand over to Lizzie. And just again, a massive thanks to Lizzie for giving up her time and for talking about Fit2Sit from a paramedic's perspective. Over to Lizzie.
Thank you. I'm just loading my slides at the moment, so hopefully you should see them shortly. Grand. So I just wanted to say thank you for inviting me to talk today. It's not often we get the opportunity to do this, so thank you for asking me to speak. A little bit about myself, I guess, to start off with. I've been a registered paramedic since 2006. Most of my work has been on the front line dealing with emergencies, urgent and unscheduled care. I've also been a critical care and anaesthetic research practitioner in a hospital trust, and I've qualified as an advanced practitioner. More recently, I joined the clinical audit team, and last year I became the audit and effectiveness manager for North East Ambulance Service. I became a regional clinical fellow as part of a leadership programme with the Faculty of Medical Leadership and Management, and I'm currently hosted by NHS England, and I work in the Urgent and Emergency Care regional team in the North Eastern Yorkshire. So I'd like to say I'm a little bit of an enthusiast for improving patient care. So recently I found myself looking at Fit2Sit. So I thought I'd just start by giving you the perspective of myself as a paramedic. Start with, I'm so sorry. And that's unfortunately is what I do say to patients when I do my frontline shifts the most often, the first thing that I say to them. And I wanted to put that there to offer the notion that the patient has been waiting for me to get there, or the ambulance to get there, for a significant time, and frequently in a position where they haven't moved much or at all. Wearing your shoes and getting dressed. It takes time, and clothes cannot easily be found. It can be an effort when the patient's feeling not well and frail. And often relatives kindly bought new slippers or shoes for patients for the purpose of attending hospital, but they're not always wearing what's comfortable or what promotes walking, confidence in walking.
Are you?
And also bags that get packed for the patient are usually packed with nightwear and not daywear. Just a few steps. Getting patients to the ambulance largely encourages mobility in my experience. The encouragement to just sit up in the bed, get up from the chair. Could you walk a few steps? And routinely asking, can you manage 3 steps up to the ambulance? Because we only really like getting the tail lift out when mobility is particularly poor or acuity is high. What about my stick or any of the patient's walking aids? Even if a patient wishes to take it, it might be discouraged if it's large or unable to be secured in the vehicle. And this teamed with the experiences of loss of aids on the last visit to hospital. It means that patients' own walking aids might not go with them. So there might be some opportunities here to make small adjustments to ambulances or codes on the walking aids to enable them to go with the patient. I'll get you a chair, wrap you up, keep you warm. It's raining outside, with all the best intentions, but we have to be sure we realise when this becomes harmful. And also, getting a chair is sometimes easier said than done. They're not always available at the hospital. There might be a search around for a chair for quite a while, delaying the patient actually getting into the department. And I wouldn't really want to walk a patient into the department to join a queue without knowing that there was somewhere for them to sit. And this might encourage staying on the stretcher if there's none available. So my current work has been around inquiry and fact-finding what's been going on in ambulance services and hospitals in the North Eastern Yorkshire. So NEAS that's North East Ambulance Service, have been running a pilot on Fit2Sit and developed criteria with Sunderland Hospital. There's a standing operation procedure being written and action cards for ambulance crews. Unfortunately for today, I haven't got any data capture from the emergency department, but I have myself done 3 days evaluation of the NEAS data, and there is some variation, but between 5 and 12% did have Fit2Sit recorded in their patient record. And on the 3rd day, I looked particularly at what opportunities there might have been for more of those patients to be Fit2Sit, and I certainly think there is definitely room for improvement there. In the Northwest, they have standing operating procedures in place. They have had a lot of quality improvement at sites when it was implemented first in February 2021. They did see an improvement in handover times, and the design is different, but originally designed to stream direct to the waiting room, and then a major seating area was developed. It depends on which hospital you go to, depends on what Fit2Sit actually means. And then we've got Yorkshire Ambulance Service. They have a standing operating procedure for self-handover. And actually, I've just been sent some more information today regarding West Yorkshire hospitals, demonstrating variation in who the decision maker is and where Fit2Sit actually is in the department. But interestingly, they've just started with a role called the Ambulance Resource Coordinator, ARC role, and it was introduced to support ambulance and hospital relationships and hospital flow. And essentially, it's a paramedic embedded within acute trust. So I thought I'd just put a little bit in here about what that role is. As I said, it's a paramedic embedded in the acute trust, and they're put there to understand a way of working, to work with the ED operational management teams to identify flow and process issues, and to build relationships. The main aim is to develop continuous improvement culture with flexibility in its approach, dependent on emergency department processes and flow requirements. And aside from quality improvement, the clinical aims really of that role is to promote stream into SDEC, self-handover or other available pathways, to provide guidance to newly qualified paramedics, technicians, or private ambulances that might be supporting the service, to manage and triage the queue by prioritising patients, especially deteriorating patients, encouraging Fit2Sit where it's appropriate, good handover, supporting the decision making made by the paramedics, seeing opportunities that could be this patient can be treated elsewhere, or maybe there was opportunities in the community that were missed. As a result, I don't have any data yet because it literally has just started, but I've spoke to a few of the ACTs to get a little bit of feedback on how they're finding Fit2Sit in the departments. And a few of the comments have been, we're reducing the number of trolleys taken up in the emergency department. We're speeding up ambulance turnaround. We really do feel like we're improving the flow at the front door and building good relationships. But there are limited wheeled recliner chairs. There are frequent disagreements between what patients, crews think and hospital staff think are Fit2Sit. And there are difficulties staffing the Fit2Sit area, maybe with a doctor, a nurse or a healthcare assistant, depending on the hospital. So I thought it'd just be handy for me to just show you the rapid handover Fit2Sit criteria checklist that I've got from Northwest Ambulance Service in blue and Northeast in the green and red. Unfortunately, I haven't had a Yorkshire Ambulance Service. I don't want to misrepresent, but I haven't had it yet. So apologies for that from anyone from Yorkshire Ambulance Service watching this. But what it does is it just really highlights the variation and the difference in interpretation in what Fit2Sit actually is. Even where it's more embedded in Northwest Ambulance Service area, there still seems to be quite a lot of variation. At some sites of the clinical handover, and others none's required. So for me, I'm kind of finding that there seems to be two lots of Fit2Sit. There's Fit2Sit majors and Fit2Sit waiting room. And as work is currently ongoing, I'm also collecting hospital Fit2Sit procedures in an attempt to provide a full overview to the region. So I thought we could just run through some barriers, what I've collected from speaking to quite a lot of people in the North East and Yorkshire. So the different interpretation, the local interpretation of the definition of Fit2Sit and or self-handover. What does it actually mean in an emergency department versus for an ambulance trust? Variation of how Fit2Sit is applied. Clinical oversight, no clinical oversight. There's a lack of alignment over the definitions between what patients, crews and hospital staff think are Fit2Sit. Access to wheelchairs at the hospital or patients' own wheelchairs. Mobility devices can't be secured on the emergency vehicles. And this impacts on occupational therapy assessments in the emergency department. And perhaps there's a lack of formal training on the benefits of Fit2Sit. So on to my recommendations. And aligned criteria. Irrespective of locality, working with each other to get the criteria right for them. I really think the ARC role is really important for learning cultures. I think it's a good idea to gain the knowledge, address attitudes, cultures, enable the ARC to have a conversation with the paramedic in the queue, maybe changing the culture a little bit. You know, instead of sending your patient here, SDEC could be inappropriate. Or did you know you had this in the community? Having a real knowledge, embedded knowledge of what the emergency department flow is versus the ambulance flow, or ambulance requirement, I would say. It has to be a shared decision, I think. And again, this role makes it a shared decision. The paramedic speaking to a paramedic, the ARC speaking to the hospital staff. If we could share a decision on who is safe to fit to sit, is it a certain type of patient? Does it need to meet a new score, acuity level? And do they need monitoring? Ensure wheelchair availability. This delay, if it's not there, it delays getting the patient into the department. And we might use a stretcher instead. Enable patients to take home walking aids. This might be a strap or a bracket in an emergency vehicle to allow them to be secured down into the ambulance. Or like I said before, QR code or stickers on the patient's walking aids. And I feel just like there is a real opportunity to maybe promote Recondition the Nation and PJ paralysis to frontline staff. That's the end of my presentation. Thank you very much.
And I say a huge thank you to Lizzie. A fantastic presentation. Thank you so much for kind of bringing together the perspectives from across those different services. Really interesting to see kind of processes, people, and logistics. So the importance of having the processes agreed, but then the way that shared decision making and people may kind of make challenges, and then the absolute importance of the practical things like having the wheelchairs, the walking aids, the infrastructure in place to facilitate it. And then the really interesting discussion, which can perhaps bring out in questions and answers, about the role of the ARC coordinator and the purpose of that and what that brings. So much content in there. Thank you so much. And I am now going to kind of move from that shared decision point from when the paramedics and the ambulance crew bring that patient in and they may have identified them as fit to sit, to acute perspective, and what then happens. So can I introduce Dr. James Harrison, and he's going to talk from an acute perspective about fit to sit at the North Middlesex. So thank you, James, for being with us.
Right, let me just get this sorted. Okay, can everyone see my slides? Yep. Okay, so my name is James Harrison. I'm an A&E consultant at North Middlesex. I'm going to talk to you about our sort of fit to sit journey over the last sort of 6 years, and sort of how we've taken this philosophy of fit to sit and kind of distributed it through our emergency department. This is a picture of our hospital. It's the front end, and it's bright and shiny. As will come as a surprise to anyone that the emergency department doesn't looks a bit more careworn, I suppose. But we're a hospital, we're a DGH, we're in North East London. We're in an area of quite high deprivation. We see about 180,000 patients a year. We do adults, paediatrics. We've got an urgent care or urgent treatment centre, and we see about 100 ambulances. Receive about 100 ambulances a day. At the start of this journey, we'd seen a significant increase in the number of patients coming into the emergency department because a local hospital's emergency department closed down. That was Chase Farm. So we were seeing sort of an increase of 150 to 100 patients a day. And at the start of the journey, we're seeing about 500 a day on average. Towards the end of this journey, up to sort of an average of 600, maybe a little bit more. And it's continuously increasing. And so I think in the last couple of months, we've had 6 days, I think over 750, all within broadly the similar amount of space. So at the start of the journey, and this is not a slide I'm particularly proud of in any way, this is a headline from the Mirror, and this is what the CQC thought of what we were doing. And I just described the system that we had, which was there was triage of ambulances and walk-ins were triaged. And this is just for adults. Patients could go to resus, patients could go to the urgent care centre, but the majority of patients were going into this 18-bedded area with a big waiting room attached, and it was one single queue. And you can kind of see then that if you've got one single queue, it's not, it's relatively easy to imagine how on earth this actually, how on earth we managed to miss a patient, and they deteriorated. No one really had any oversight of that. So, and we were sort of in the bottom 10, I think, in terms of ED performance at the time. We had ESIST heavily involved, and Matthew Cook, formerly of ESIST, basically had his own chair in our emergency department. It was really quite, we had some very intensive support. And at the time, there was a recognition that we were running an unsafe system, that and as a consequence, I think our staff were very sort of felt disempowered. They became disengaged with the process. So we kind of had to take some fairly radical steps to think about what we were doing. We redesigned the emergency department using these principles. Now, the first sort of 4, I guess, are kind of straightforward. We wanted to focus on how we manage the risk in the emergency department and improve our ambulance offloads as well. And one of the things that we really try to do is move from this sort of serially arranged system with sort of patients having these really quite prolonged journeys going from one place to another place to another place, and there would only be one person at each location, so there would be these enormous bottlenecks, to kind of move to a more, well, we called it parallelism, don't even know if it's a word, but the idea that you could have multiple patients coming to one location and having lots of sort of nodes of activity where things could be done in parallel, and generally kind of try and shorten patient journeys. And at the time, and of course now to an even greater extent, we were suffering from the impact of exit block, and we realized that we needed to be able to try and generate some internal flow in the emergency department to keep things going, and sort of alongside that, to also flex our system in response to surges in demand. We've got a population that's very, very heavily representative, or no, the working age adult is highly represented in our population, so we get a lot of inflow after 5 p.m. So the key thing really we realized, or that we wanted to do, was to think about how we could try to do less care kind of in cubicles with patients lying down and deconditioning, and more care on chairs. The idea really is that we were applying that Fit2Sit question to the patient at multiple times throughout their journey, so from the ambulance all the way through their time in the emergency department. What we've got to, we didn't start like this, but we've got to a position now where actually pretty much all of the members of the team are empowered to ask that question and to challenge on that. Do you think this patient can sit in a chair? Do you think this patient needs to be in a bed? And initially we started with just an area with 4 chairs in, and over time there was 4 chairs in the ambulance receiving area, and over time we've managed to increase that. And in fact, now our current kind of configuration of our emergency department is, if we exclude resus and the urgent care centre, that middle bit of the emergency department is 50% chairs, 50% sort of cubicles, beds. So we kind of, the idea is that we're kind of running a very ambulatory focused emergency department, with what we hope to be consequent benefits in terms of deconditioning, and obviously there is a capacity benefit as well, to because you can fit more chairs in an area than you can beds. So how does this actually work? So with the sort of the front door, I suppose, to ambulances at least, is something that we call the FIT zone, which stands for fast initial treatment. And at this, the patients are entering here, and we're asking that question straight away: is the patient fit to sit? The patient's fit to sit. There's kind of 2 routes that they can then take. If they don't need anything done immediately now, their investigations are requested and they go and sit in our waiting room, and then there's a separate area where the patient can have their blood tests and so forth. And if the patient's a little bit more unwell, requiring some immediate treatment, then they're coming into these chairs here, and of course similarly they'll be going into the beds there. We do direct ambulance crews directly to the urgent care centre, and that's done based on the ambulance's decision. But kind of unlike what we were hearing about what's happening up in the northeast, we haven't really managed to have ambulance crews making the decision, ambulance crews doing a kind of rapid drop-off model. What we try to do post our team kind of at the front door so that we can do handovers as quickly as possible, and then if we've got space, then bringing them into the most appropriate area. In terms of the team structure here, we've been through multiple iterations. We've had nurses doing it. We've had a kind of pit stop principle. Really, we've kind of ended up with a bit of a blend. When we designed this, we realized that this would be perfect for ACPs, but at the time we didn't have any. 5 years later, we've now had some colleagues who've gone through that training, and now they're actually starting to take a greater role in making the clinical decisions about what's happening in this area. But our current configuration is 3 nurses, 3 HCAs, and an ACP and a consultant usually, or a consultant or registrar. And the idea is that there's a very rapid handover from the ambulance crew, followed by a more detailed assessment done by the ACPs and the consultants, which basically they decide on the initial investigations and treatment, and then they're framing the case for the junior doctors who see the patients subsequently. In addition to sort of framing the treatment, also the senior decision makers are kind of offering some kind of criteria for continuation of treatment, so that they don't need to go and re-review the patient. They can set criteria for when the patient, you know, is safe to move, or, you know, treatment is no longer indicated. Now, of course, not all of our, you know, it's only a minority of patients to arrive by an ambulance. We also then have our walk-in patients, and again, we're kind of pushing this idea of fit to sit with our nurses. Now, the majority of these patients will be fit to sit. The question we're asking our streaming nurses to say, is this patient okay to go and sit in the waiting room and have some investigations done, and can you request them? Or is this patient more unwell? Do they need a sort of an acute assessment right now? So geographically, it's all quite close together. So we're kind of using this fit zone to actually be a receiving area for patients who need that immediate medical assessment. So, for example, a patient with acute chest pain or acute asthma. So this area is actually not just an ambulance receiving area. It's really a sort of a sick person receiving area, but has got flexible capacity. What this kind of fit to sit idea really has done is that we're kind of encouraging the nurses in streaming to identify what's abnormal, what needs investigation, what needs treatment, and what needs immediate investigation, what needs immediate treatment. And that these kind of ideas are really feeding into our PDN's kind of development program. So in that way, we're trying to kind of, you know, encourage and educate our nurses through their, you know, levels of development. But of course, you know, ambulances don't stop, walk-ins don't stop. So, you know, it wouldn't work that this is the limit of our sort of ambition regarding treating people in chairs. We have a majors. It's, you know, it looks like everyone else's majors, I suppose. And then we've got this area called sit to treat chairs. So the patients who have been offloaded into these treatment chairs are then filtering down through into the sit to treat chairs for continuation of their treatment if necessary. I mean, we started with quite a small number of chairs, and now, as I said earlier, we're kind of 50-50 chairs versus trolleys or cubicles, and that's what I advise anyone who was kind of considering going down this kind of route, is start with a small test of change and then slowly expand and expand and expand as your ambition kind of increases. These sit to treat chairs are also where the streaming nurses are encouraged to bring patients who they feel don't need that immediate medical assessment, but they know exactly what treatment they need, and they're coming into these sit to treat chairs. And we're being quite sort of rigorous around patients only being in this area if they're on active treatment. They're not on active treatment, and they can sit. They usually go back out into the waiting room. You know, we're cautious about making that decision, but generally speaking, that's what happens. The other thing I'd say is that when you're creating a big area with lots of chairs, it's very difficult to make a decent assessment of a patient. it's not very, it's not dignified to have an examination in that kind of environment, and there's obviously it's not at all confidential. So we've got a number of sort of assessment cubicles where we're taking patients for for conversations that require a great degree of privacy, and of course the any kind of examination. Who's next? I've got this slide. So what we've tried to do is to split our emergency department essentially into these two big streams. One is the major stream. The other one is this whole sit to treat stream, which includes patients who are in the waiting room and patients who've had some initial treatment, up here, and then having continuation of their treatment down here. The idea is that this Fit2Sit question that we asked at the very beginning and have continued to ask throughout the patient's journey essentially stratifies patients by risk. So if you're not able to Fit2Sit, you're almost certainly a higher risk. And if you are able to sit either with treatment or without treatment, then you're probably at a lower risk. What we found that in times of extreme congestion, that before that when the department gets very congested, the actual areas become their own silos, and people get their head down, and that there's not really an awareness of what's happening in other areas. So what we've actually done is extended the queue using our kind of our electronic patient tracking system, so that the queue for the sit to treat queue and the doctors looking after that queue are also they will see at the very bottom of their queue the patients who are in that the fit zone, the chairs, so we can see the patients that have just come in. The same with majors, so these patients of course are all in the queue, but then these patients are actually at the beginning of the queue. The idea is that you break down those silos and that we've got a differentiation in our queues, not based on location, but on a determination of their acuity and their risk based on this Fit2Sit question. Now, it's not absolute. It's not, there is, of course, there has to be some flexibility in that. But in general, that's the way things are kind of divided. I talked at the beginning about internal flow generation. This is a really important thing, and it's become more and more important, I think, as our exit block has increased. And our, and the surges of in our attendances have increased as well. But we're always trying to move patients from beds to chairs, from chairs into the waiting room. In majors, we're trying to move patients, potentially move patients from them. If we've made the bed, it does happen. Patients do get better, but to step them down from being in a bed to being in a chair, from being in a chair and into the waiting room. And this does require a lot of quite active management of the department and a high degree of awareness about who's where and what they're doing. So it really does help to have a lot of rigor around the checking of where your patients are and what they're doing and where they're tracked to. I'm not going to mention too much about this. I can talk about that if anyone wanted to hear about that at another time. But I just wanted to kind of summarize some of the lessons that we've learned through this process. And I've just got some pictures here to help me remember. This is a graph that someone created, not a graph, it's essentially a nomogram, but it's a tool to predict what your likely attendance is going to be based on what your attendance is currently, earlier in the day. So kind of what kind of day you're looking at. It's slightly useful, but the point is that this has come from quite a lot of analysis of data, and if you're going to do any kind of sort of aggressive improvement project within your emergency department, the data is your friend and it will help guide you to the next iteration of what you're doing. This is one of the sticker that was produced, which I quite like, which is from our frailty team. Obviously, this is very advantageous to preventing deconditioning, having an aggressive kind of Fit2Sit policy throughout the emergency department. And actually, when we started this work, the awareness of frailty was not actually that high. But over time, because over time we have found that there is a lot more awareness of frailty. And along with frailty and other developments that we've had in our hospital, like increasing use of ambulatory care, surgical ambulatory units and things like that, because we're very focused on the ambulating patient, as soon as these new ideas get developed downstream, we're well set in the emergency department to kind of push patients on that journey. So to push patients to ambulatory care or SDEC. Well, one of the things here, this is a picture of our simulation sessions that we do. So it is a bit of a complicated system. There's a lot of moving parts. And so during the kind of phases of deployment of these ideas, what we've done is take time out with the team and basically have these sort of simulation days with sort of counters, so that you can think about how we can manage risk, how we can move our resource around the department to deal with, surges, to deal with the problems of exit block. Here, this is a graph that shows our position in the league table of NHS England ED performance. So back here, bottom 10, then a couple of years later, we managed to get up, we peaked at sort of top 30. This graph is not here to boast, actually. This is more of a to remind me of what happened here. That actually our improvement actually started to stall relative to the wider group of EDs. That's not because we took our foot off the gas. That's because really at this point there were external pressures that were starting to come to bear to what we were doing that we couldn't control. So really what I want to say here is that this kind of thing is not a panacea for totally improving your emergency department to make it the best. You will get a certain amount of improvement in what you're doing and a certain amount of improvement in patient experience, but there are then other factors which kick in, particularly around staffing levels and exit block. Final picture here is a picture of Tom, our service manager. I think, well, he's driving a digger, but this is, I think, the third iteration, the third redesign of the hospital, of the emergency department within 5 years. When we started, we didn't have any money. Because we did small tests of change and iterated and demonstrated that we were moving in the right direction, then that liberated money. And that's kind of my final point, really, that I'd say to anyone, really, is that if you're trying to do something radical in your emergency department, start small and then make the case for additional funding or extra funding from your organisation. Thank you.
Thank you so much, James. That was fantastic. A brilliant follow on from Lizzie. Hugely practical, some brilliant advocates of kind of the change process, the change management process, use of data, redesign, so much content in there. And I think a real richness. And thank you for the honesty around the challenges, and really impressive to see what's been achieved. So thank you so much. I'm now going to hand over to Dan, Dr. Dan Bowden, who will introduce himself, and he is going to very ably manage the next part, which will be questions and answers and Menti. I'm also just going to highlight that we're going to put some resources into the chat. We'll collate these and put them into the presentation and circulate that after, but just for anybody that wants to pick up resources relating to Fit2Sit and other bits and pieces, we'll be dropping those into the chat. So you've heard enough of me. I'm going to hand over to Dan to manage questions, so please, if you've got any, do be ready to put your hand up, and thank you so much again to Lizzie and James. They were fantastic presentations.
Thanks, Jen. Yeah, for those who don't know me, I'm Dan Bowden. I'm an emergency medicine consultant doing my clinical work at ULHT at Lincoln and Boston. And I'm a clinical director for eSyst. Fascinating. I've learned the four FS, a service manager driving a digger, and the fact that patients do get better was quite encouraging from James as well in the middle of a kind of tough time in urgent care. But genuinely, really thought-provoking presentations, incredibly patient-focused. I love the fact that Lizzie kind of came at it from a what's right for the patient, and it just shone throughout the presentation, and James gave a really good practical example, and there's loads of learning from both. One comment from me, then we'll go to Erica for the Menti, and then on to questions. I call this a tricky triangle. There's a triangle that we try and manage in urgent care and in the NHS generally, and that triangle is quality, performance and finance, and that's a triangle that we're always trying to kind of square that or circle off that triangle. And we come at it from different angles, and clinicians come at it from a kind of quality angle often. The finance representative will come from a finance point of view, and then performance wise we're becoming more and more into our psyche again as we move back towards the 4-hour standard. And this is one example where actually we can achieve all three parts of that tricky triangle. We can do the right thing for the patient by getting them up on their feet, doing the right thing, preventing reconditioning, doing the right thing from a quality point of view, It's clearly good from a kind of performance perspective in terms of ambulance handover, in terms of getting, thinking about same day emergency care, thinking about from a 4-hour standard point of view. And from a finance point of view, it's freeing up ambulance crews, getting them back onto the road from a number of different avenues. It's the right thing from a financial point of view as well. And there aren't many of those in the NHS. This is a really, really important thing. It's not a silver bullet, but I think it's really important that we have this webinar, that we socialise Fit2Sit. 2 different parts of the questions. We'll go to Erica for the kind of mentee side of things and get some feedback that we've had online, and then we'll ask for just hands up, and we'll go through any questions that people have got, and we'll then channel to the most appropriate person to try our best to answer. So over to you, Erica.
Thanks, Dan. We haven't had as much kind of input through the mentee, recognising how busy everybody is. So I'm going to share it now, and we'll just spend a couple of minutes. There's only one question, and we're just keen to kind of reflect very briefly with you all on the challenges and barriers that you are currently kind of facing if you are kind of trying to implement Fit2Sit. I'm hoping many of you, if not all of you, will now be familiar with Mentee and how to access it. So you can do that 2 ways. You can either go to mentee.com and enter the code on the left-hand side of the screen, or else use your phones and scan the QR code, which will take you to the page. I'll just give you a minute or so just to get sorted. Maybe a minute is too long. Is everybody okay? Have we managed to get everybody on the screen? So I'll stop sharing this and we'll move straight to the question. We've already got a couple of answers, but what challenges and barriers have you faced or are you facing currently when implementing Fit2Sit? And we've got some feedback already from colleagues. So back to the people, Dan, so something about hearts and minds and winning people over, which I'm absolutely certain is important. Hesitation for patients to sit in chairs, so something perhaps about our appetite and the way we might want to approach risk. James talked about capacity. I guess this could be 2 ways, couldn't it? Our capacity and headspace to do the work, but also the physical environment in the emergency department to allow you to do something different. We've got 8 responses so far, so I'll just allow maybe a few more seconds, Dan, and then I'll hand over to you. Mental health patients, I'm assuming this is a concern potentially about acuity. We might want to pick this up, Dan, perhaps in the kind of question section.
Yeah, there's definitely something about that. There's definitely something feeding through around risk, and I thought how James, for me, Fit2Sit is our biggest risk area currently within the emergency department. How James has talked through that kind of process for how they manage risk was really that's not something that's commonly done. So that was really enlightening, I think, and the mental health side of things as well. Really, from a mental health perspective, that can be really challenging for the patients and staff. Okay,
we haven't had any new responses, so I think maybe we can stop here or pause here for the minute. One more. Yeah, we talked about Fit2Sit perhaps, and the connection of Fit2Sit with other streams, whether that's urgent treatment centres, same day emergency care pathways. So we might want to pick that up as well in the question.
Great. Should we open up to questions around sort of barriers and challenges, Erica, or do you want to go on to the rest of the mentee questions, or should we do that one first?
No, I think, shall we do that one? The other question was about the role of Fit2Sit, and I think we've covered it adequately, haven't we, throughout the presentation?
Fine. So we'll open up to kind of to hands, either physical or electronic hands for questions that may be linked to kind of barriers that's been a mentee question, or we can open it up more generally. So over to you guys. Anything that people want to ask? We want this to be as useful and as engaging as possible. So, Jen?
This is directed at James because it revolves the mental health patients. There's quite a good model of joint mental health triage at North Mid, which manages some of that risk. Do you want to describe it, James? And that might be helpful for some of those concerns.
Yeah, so our liaison team for most of the time are available to come and do a joint medical and mental health triage. So we've got a cubicle allocated where that assessment can happen, and we actually have a couple of years ago managed to get some funding for a very specialized mental health unit, which is essentially the area that the triage patients are then fed into, which is ligature free. So for the more high risk patients, that's where they go. So it's again kind of it's about continuing that sort of golden thread of where you put what kind of assessment you make of the patient when they come in, and then having somewhere that's appropriate to receive them subsequently.
Great stuff. Thank you, James. Really, really useful. Any other questions? I've got one in a minute, but any other questions for anyone else? So the one I've got, and it probably is for James again, but it may be for anyone actually, and it's at the minute we're obviously thinking about how we evaluate our work within ESIST or any work that we do in improvement. How do we show that we've made a difference? And I'm interested to know how we, and it may not be a kind of quantitative measure of success, but how do we know that Fit2Sit has done the job that we want it to do? And have we got has anyone got any thoughts, James in particular, but has anyone got any thoughts on kind of measuring success and know that we've done the right thing?
I'll kick us off then. We did, so in terms of our measures for looking at this stuff, we did sort of time to first assessment, time to that definitive assessment by a senior clinician, time to first investigation and completion of first investigation, or time to the conclusion of treatment, were all things that we measured to demonstrate that we were moving things in the right direction. The other thing that we looked at, which is really interesting, is the time, a comparison between the time taken from when a doctor clicks on a patient for the definitive assessment and how long it takes for them to discharge the patient or to refer the patient, comparing that cohort of patients with those who'd had that pre-assessment through the ambulance arrival area, through the fit zone. And you can kind of demonstrate that, and I guess that's more focused a little bit on demonstrating that front loading everything does work and kind of reduces the amount of time it takes to reach a definitive kind of fit to proceed kind of decision. But those are the kind of things that we were measuring. And the great thing about those is you can measure them for every single patient. So, you're looking at hundreds of patients over the course of a month. So, there is a lot of variation, of course, depending upon acuity. But over time, we found it sort of averaged out and we could see trends.
Really, that's fascinating. And a separate question, either now or different time, might be whether how we discreetly staff that area, to make sure that we're getting better and better at matching capacity and demand across an ED in its entirety. I'm not sure we're as good as we can be because of, I think, some of the fluctuation numbers that we get in Fit2Sit of how do we get the medical, the nursing, the allied health professional staffing right in a Fit2Sit area can be tricky, can't it? Erica.
I guess just picking up on the theme of kind of data and feedback, James, is there any qualitative feedback that you've kind of considered as part of this process? So whether that's, I guess, from patients or from staff. So I guess, what does the evidence kind of point to in that respect?
So we have had a couple of surveys from HealthWatch over this period. The things that were coming back from patients was, I got seen really quickly. Because for a patient, you see a doctor or an ACP, it's very difficult to know whether they're a junior doctor, a registrar, or an ACP, right? But this idea of being seen very quickly, the minute you either come off the ambulance or you've walked in and come off the stream room, that really does resonate with patients, and I can understand why. And the other thing is that we did do, we didn't really do formal surveys of our staff, but anecdotally, there is a massive change in the way our staff feel about what they do, and that kind of empowering staff and growing their skills within this framework of let's try and do things as quickly as possible and make the most of our space, and let's be creative about how we use space. People have reported that's made them feel that they're enjoying their work more. There's a lot of other things that happen in emergency departments that make people enjoy their work less, but this is
but it's a helpful factor. Thank you so much for that, James.
So Rob's got his answer. So Rob for a question, and we've got a question from Lucy around 12 hours, which I'm happy to answer, and I've got a question for Lizzie in a minute.
That was the one I was just drawing your attention to, Dan. As long as you got sight on Lucy's question, that you're free to go.
Thanks, Rob. Yeah, I'm happy to give I work in, I know this is recorded, but it's a bit late now. I work in an organisation which is very, very challenged for 12 hours from arrival, and I've certainly had patients over 36 hours in a chaired setting waiting a bed. We have got a lot better at that. We do hourly rounding. We offer food and drink. We do observations, but it's not easy, and a lot of our time is spent, as Lizzie said at the beginning, apologising to patients, saying how sorry we are, but actually still most patients would rather, oddly, be in a chair that's relatively comfortable. They can get up and walk around rather than being kind of tied or attached to a trolley with the sides up and unable to get out of bed. So it's by no means ideal, but actually, whether you're in a chair or a trolley, unless you want to sleep, that's the tricky bit. If they really want to sleep, then we then have that open, honest conversation. There's times when I have put patients into a trolley purely to allow them to sleep, which is kind of sad in 2023, unfortunately. Lizzie, I had a question around sort of education. One of the big bits here is hearts. It's kind of hearts and minds, isn't it? And that's hearts and minds sometimes of patients, and then it's hearts and minds of both ambulance staff and ED staff. And you highlighted different SOPs with different. Have you seen good examples of the sort of education side of things for staff, and how ambulance trusts have gone about educating their staff that it's the right thing to do? And if you haven't, then I might come to others and see if we have.
Yeah, I guess because it's quite early in the pulling the data or fact finding in the region, less has been on the training, but there's been quite a lot of just anecdotal comments of trying to interpret what it is, and no comment of training. Myself, I've had a PowerPoint presentation in a annual training, but really I think what would be better would be just, as James said, every touch point just being reminded all of the time, really embedded, which sort of is why I spoke about the ARC role, because I thought that they were working with the hospitals and aligning the priorities. And you can tell that I'm passionate about patient care, and it would be reminders all the time. It's okay knowing the concept, but then that's however many paramedics going out in the ambulance service to different hospitals that are then making their own interpretations of what that means. Yeah, if that helps answer that question, Dan.
Yeah, it does. And the touch point bit, that having that at the front of our mindset all the time is really important, isn't it? So I think before we close Q&A, just one final question from Patrick, and then we'll go back to Jen to conclude. Patrick.
Thanks, Dan. It's not a question, it's in response to what you were saying. So I'm a massive advocate of teaching paramedics, totally flipping it on its head and making Fit2Sit a clinical strategy. I'm a paramedic by background. Paramedics as a workforce responded incredibly well once they were well educated. Currently in the English curriculum, there is very little, if anything, around deconditioning. The flip side is our colleagues in Scotland and Ireland, the Scottish Outpatients Frailty and Falls programme in 2018, started to interject in paramedic training around deconditioning specifically, linking them, giving them rotation into the community, even as student paramedics. It had a massive impact on the ability for paramedics to feel more comfortable in what they were doing, whereas I've seen across the ambulance trust, Yorkshire Ambulance, you mentioned, Lizzie, they have 2 separate ones. They have a Fit2Sit, but they also have one where I can't remember the name of it. They have another one where they can make the decision to leave. So they're almost splitting that decision and risk. So yeah, the education and flipping it, it's a deconditioning strategy, not a you are able to fit and sit there so I can bugger off.
Thank you. I've just put in the chat, but really fascinating, isn't it? And if we can get some of that kind of those resources and information to kind of align with the webinar, that would be really, really useful. And the, you know, the difference between our countries or in the UK, if there's lots of education happening outside of England, that would be good to share as well, wouldn't it? Good stuff. Nothing else from me. We'll pass back to Jen just for kind of closing remarks and next steps. Thank you.
Thank you, Dan. Thank you again to James and Lizzie, and thank you to Erica and Rob and team so much for helping set this up. I hope that those who've been able to join us have found it helpful and useful. I've certainly learned things from listening, and I think that there's kind of a wealth within the presentations which we'll share afterwards. The recording will be available, and there's loads of resources referenced in the chat which we'll link together and put onto the presentation so that it's in one place for you. If you'd like any further information afterwards, as I said, please do drop us a note. I've put my email on the beginning of the presentation. But really, I think it's been a powerful reminder of putting the patient at the centre, of the power of Fit2Sit and what that can do for the patient, but what it can also do for the staff, both across kind of the challenges of being a paramedic and seeing these people and knowing they could be sat. And then the challenges for staff in an ED and being able to support them to do the right thing by patients. So it's been a fantastic reminder of what's right for patients is right for staff and helps us to improve the process for everybody. Just to really end by saying thank you for those that attended, thank you for those that presented. I hope it's been useful. We welcome feedback in any shape or form, and I hope that the rest of your day is good. Thank you very much.